I'm part of the Endometriosis Center at NYU, and we're doing a webinar for our regular series. And tonight we're going to talk about endometriosis and the overlap between endometriosis and IBS, another really common disorder. So I am, again, one of the minimally invasive gynecologists. I completed a fellowship in, and we also have Dr. Rajapaksa with us. And she is one of our great gastroenterologists who works at Trinity with myself. We work at the Trinity Center, NYU, which is down in the financial district. It's a pretty large practice, multi-specialty, and we have a wonderful GI group that is very robust there. I'll do a minute more of an introduction to myself. I finished a fellowship in minimally invasive gynecology in 2014 and worked with Dr. Sina Najat in Atlanta, Georgia, who specialized in endometriosis and fertility surgery. And I joined the NYU staff in 2019 and have been working and enjoying our wonderful collaborations and staff in the interim. And so that is myself, Dr. Rajapaksa.
Hi, everyone. Thanks, Erica. I'm Dr. Roshini Rajapaksa. As Dr. Dunn mentioned, I'm a gastroenterologist in New York at NYU Trinity Center, which, like we said, is located downtown in Manhattan. And I've been with NYU since I came to medical school at NYU in 1993, so quite a few years. I did all my training for gastroenterology, first internal medicine, then gastroenterology at NYU, and then I joined the faculty. So I basically have had one job for my entire career, which has been great. I've also done some media work as a medical correspondent. So some of you may have seen me on TV as Dr. Raj, talking about kind of wellness topics and health and science and news. And I've written a couple of books. Most recently in March, I wrote a book called Gut Renovation, which is all about how our gut health and specifically our microbiome can impact every part of our body and our well-being, and why that's so important to take care of our guts. But really excited to have this interesting discussion today.
All right, wonderful. So we are going to do a little, so I'm just going to share my screen real quick. Share screen. Okay. All right. I just put together so the format of this is it's pretty casual. We're going to do a top 10 list. Start. Okay, so that's us. We're going to do a little throwback to David Letterman with our top 10 list. We're going to go through top 10 questions that we kind of get regarding the overlap between these two diseases, these two fairly common diseases. Endometriosis, as you probably know, affects 10 to 15% of reproductive age women. It is a fairly common disorder. And for women with pelvic pain and abdominal pain and infertility, it affects almost 50%. So it's a pretty high amount. We often get a lot of questions, like how can you tell like whether or not it's IBS versus endometriosis? So this is a very great forum webinar to kind of go over those things. So top 10 questions. So number 10, what are the most common symptoms shared between endometriosis and IBS? I would say number 1 is abdominal pain, pelvic pain, more cyclical for endometriosis, but probably and likely non-cyclical for more IBS. But cramping, bloating for sure, nausea, vomiting even, that we commonly see. How about for your patients with IBS? what are their most common complaints in general?
Yeah, well, I just want to start with a definition because even though a lot of people know what IBS is, just in case they don't, this stands for Irritable Bowel Syndrome, and it's a very common condition worldwide. Estimates range from 10 to 15 to even 20% in certain populations. And it basically is a condition that involves abdominal pain that's associated with a change in bowel movements or associated with defecation. There's some stricter criteria to actually diagnose it, which we'll talk about, I think, in a little bit, but that's what the condition is. But it very often involves symptoms like bloating, certainly changes in the bowel movements like diarrhea or constipation. And I think one of the interesting things why we're talking about this topic today is there is so much of an overlap with symptoms of endometriosis. And I think also, you know, when we talk about the menstrual cycle and how certain GI symptoms, gastrointestinal symptoms can occur during different times during the menstrual cycle, that actually is relatively normal, quote unquote. You know, the hormones and the chemicals that are released at different times during a woman's menstrual cycle can affect the bowel and can affect contractions of the bowel that could lead to looser stools for some people or constipation for some other people. But usually that kind of interplay is heightened if someone has endometriosis, and then heightened even more if they have endometriosis and irritable bowel. So it can get a bit confusing. And I think if there's one takeaway that we'll sort of all come away from this evening with is that both the gastroenterologist and the gynecologist have to be very aware of the other person's condition, you know, the other doctor's domain, and keep it in mind because there is such a overlap of symptoms. But yeah, to answer your question, Dr. Dunn, the most common symptoms I see with my patients with IBS definitely involve abdominal pain or discomfort, bloating, and constipation or diarrhea.
Yeah, I agree. I think there's a great deal of overlap. And I think that's why we have these multidisciplinary teams and referrals to, gastroenterology, pain management, and, like pelvic floor physical therapy, because it's certainly like a something that is not always cured with just one treatment or one, pathway for sure. And so we'll go to that transitions us to question number 9. Among women with endometriosis, how often are bowel symptoms noted? And so it's a very, very high amount. Several studies quoted between 80 to 90% of women with diagnosed with endometriosis often have associated bowel symptoms. Certainly these bowel symptoms are like heightened above and beyond the normal changes of the menstrual cycle. But and certainly there's a lot of concurrent diagnoses. Like among adolescents, almost 24% of adolescents diagnosed with endometriosis also had concurrent diagnosis of IBS. A little bit less for adults, more around like 7 to 10% of adults I found were also had a concurrent diagnosis of IBS. But certainly a lot of the women that are referred to me for endometriosis, like diagnosis and management, are currently working with gastroenterologists or have been working for a long time with gastroenterologists. And, the primary symptom are like these changes in their bowel symptoms, like chronic diarrhea, constipation, both of these together.
Yeah, it's really interesting because I think we're still learning both from endometriosis and for irritable bowel syndrome. What are some of the underlying mechanisms for why women experience, the pain or the discomfort that they do? I mean, with endometriosis, there's clearly endometrial tissue, where it shouldn't be, but even with that, sometimes the pain seems to be out of proportion. And so I think there are some common pathways for both conditions in terms of how people experience pain. And, we call it sort of a visceral hypersensitivity, where your body is just more reactive to certain nerve signals compared to someone who doesn't have that condition. And so you're going to experience more pain. So I definitely think that's part of the overlap there. And then Dr. Dunn, you could maybe just briefly touch on, when the endometriosis actually is literally affecting the bowel, in the bowel.
Right, right.
I'm sure it could cause even more bowel symptoms.
Oh, yeah, certainly. So there's a certain amount of pain during the menstrual cycle, but when endometriosis does like implant on the surface, or even like in the deep invasion of the bowel, which we do see quite a bit with people with, sometimes people have actually no symptoms and deep invasion. So endometriosis is a very interesting disease in that the amount of disease doesn't really correspond with the amount of pain that people actually have. So some people with a small amount of endometriosis can have a great amount of pain, and people with tons of endometriosis, like everything is stuck together, there's deep invasion, actually don't have too much. So we can't always go by like how, the amount is equal to the amount of endometriosis present. But some people with, significant endometriosis and deep invasion, um, they they will have like really severe pain with bowel movements during their menstrual period. And sometimes if the lesion is invading into the mucosa of the colon, most commonly, people may have menorrhagia or pain or bowel movements that have blood in them from the endometriosis menstruating into the mucosa. But those are pretty severe cases.
Mhm.
But we certainly look out and ask those questions when we're doing an intake for endometriosis. We ask about bladder symptoms. Do they have pain and a bloody urination during your periods? Sometimes it's a little hard to determine because there is so much menstruation that it's hard to decipher where it's coming from, because it's all kind of in the general area. But so we do our best to try to decipher, and certainly more and more imaging has a greater role in our diagnosis of endometriosis, like our non-invasive um, and pre I guess surgical diagnosis. Ultimately, um, the gold standard is laparoscopy for the diagnosis of endometriosis. But we have such a great endometriosis imaging department and center right now that they're actually very can diagnose endometriosis pre-surgically to tell us about how much, the extent, bowel invasion. So it's been very, very helpful for us in the endometriosis center, diagnose or pre-surgically assessing the amount of endometriosis. So we can say, oh, like you might need a bowel shaving preparation prior to surgery, like how thorough a bowel prep you might need. Will we have to have colorectal involvement, et cetera, et cetera. So getting back to um, the diagnosis, we're able to pre-surgically diagnose quite a bit now from our great imaging department. All right. I guess we can move to the next question we have, number 8. What normal changes in bowel movements are during the menstrual cycle are there? And I think that Dr. Rajapaksa already touched a bit on this, but they did note in a well woman clinic with patients not diagnosed with endometriosis, about 75% experienced some kind of GI symptom during their menstrual cycle. 50% experienced cramping and abdominal pain and bloating, and about 25% experienced diarrhea. That's a common thing right before, due to progesterone, which increases just before the period, the menstruation, in addition to prostaglandins that also relax the smooth muscle of of many different smooth muscles, the uterus and also the bowel, of course, causing more loose stools and more frequent stools.
Yeah,
Um,
I mean, that's definitely kind of almost normal for many women to notice looser stools right before or during their period. And it's interesting that some of my patients with the type of irritable bowel syndrome that's we call IBS-C, or the constipation subtype, actually the few days of the month that they feel pretty good is during their period, because the constipation gets relieved a bit because of that kind of looser stools that Dr. Dunn was talking about due to the hormones and the prostaglandins. But yeah, for some people with irritable bowel, the changes during the period actually can become more problematic than other times of the month. So it's not always easy to predict, but there are definitely changes. So we know, as I was saying with my book, we know now that the bowel and your gut functioning is so interconnected with nerves and hormones throughout your body. And this is a great example of that in terms of the hormonal changes that are going on during your menstrual cycle and how they really can impact the way your bowels are moving.
yeah. And in terms of like endometriosis, we try to almost suppress their menstrual periods in order to help some of their symptoms. Do you find that for younger women who aren't trying to become pregnant and who have IBS, that menstrual suppression with birth control or hormonal therapies does sort of help some of their IBS symptoms?
Yeah, that's a great question. The only time I recommend that is when it's very clearly tied to certain times of the month. So certainly I've had women or younger women say that, I'm fine except for the 4 days before my period, I'm in agony, and I either stop going to the bathroom or I'm constantly going to the bathroom. So if it's very clear that that's the time that they need something, then yes, I say, well, maybe you should speak to your gynecologist about really trying to suppress the cycle. But I would say most of my patients, it's not that clear cut, and they have symptoms throughout the month. They might get a little worse during that time, but that's usually not kind of the magic bullet answer.
Yeah. So getting to the next question, for a lot of us who are in the gynecology field, we actually I guess we talk to our patients quite a lot about endometriosis, but how do you diagnose, endometriosis is diagnosed laparoscopically, and also through some better imaging that we currently have, but how is IBS currently diagnosed, and what are like the treatment options that you give people, like initially and then like further down as like their symptoms worsen or like one therapy doesn't work?
Yeah, so it's very different in terms of diagnosis, very different from endometriosis in the sense that, as you just said, endometriosis, you either look for evidence on imaging or you personally will do a laparoscopy and see with your own eyes, these endometrial implants. IBS is the complete opposite in that there's nothing that we can look for on an imaging test or a biopsy or a colonoscopy, a test that I do, all the time. Unfortunately, there's nothing that we can point to and say, yes, that is definitely IBS. There's no blood test. There's nothing like that. So we call it a diagnosis of exclusion, meaning there are certain symptoms that are very suggestive of IBS, and I'll go over that in a second, but we don't have a specific test. And because we don't have a specific test, we have to make sure when someone has IBS-like symptoms, we're not missing something else. And so we want to make sure we're excluding other conditions. So for example, if someone is over the age of 50 and they haven't been screened for colon cancer, and they're talking about a change in bowel movements and abdominal pain, we want to make sure we want to make sure they have a colonoscopy and they don't have colon cancer. Or for a younger person, we want to make sure they don't have celiac disease or lactose intolerance. So there are a bunch of things that we need to make sure people don't have before we say they have IBS. And at the same time, I want to be very clear that that doesn't mean it's not a real condition. It's absolutely a real condition. And there are kind of in research settings, ways that you can sort of show that someone with IBS has different kind of nerve sensitivities than someone who doesn't. So, not to get too specific, but there's studies where they'll blow up a balloon in someone's intestine. And if they have IBS, that balloon being blown up is very painful, but if you blow up the balloon to the same diameter in someone who doesn't have IBS, they barely feel it or they don't feel it at all. So there's definitely something different going on in the intestines of people with irritable bowel, but unfortunately, we just don't have the right test yet developed for it. So in terms of those symptoms I was talking about, like how do we diagnose it? Currently, the main way are these criteria called the Rome 4 criteria, called Rome because that's where this conference was held, or experts got together and came up with a way to pretty much, catch the people that we think have IBS. And that criteria basically says someone who's had abdominal pain or discomfort associated with defecation or a change in bowel movements for at least 6 months. It started at least 6 months ago. It's been present in the last 3 months, about once a week that they're experiencing those symptoms. And then there are subtypes. So there are people with IBS, diarrhea predominant, constipation predominant, mixed, some who have more bloating, and then some who we just don't put them in a subtype because they kind of have a whole bunch of things. So that's really how it's diagnosed. And then in terms of treatment, I always start with looking at the diet, and we're going to talk about more specific dietary recommendations, I think, a little later, but, trying to cut out certain food groups can be helpful. Certain types of vegetables can cause more gas, and so we talk about that as well. But then probiotics is something that I think is always worth exploring because we do think that irritable bowel for many people is due to an imbalance of good and bad gut bacteria. And then there's somewhat more recently a treatment that works quite well for many people with IBS, which is actually a short course of a very specific antibiotic. We usually don't like antibiotics for the gut because we think it kills all your good flora, and we try to avoid them if we can. But this type of antibiotic actually works very well for IBS. It kind of kills off the not so good bacteria and helps your gut rebalance and populate with the right
Oh,
bacteria.
that's really interesting. I hadn't heard of that antibiotic. What class of antibiotics is that?
Well, Xifaxan or rifaximin, it's it's in its own class in a way, and it can be very effective. Sometimes we give people a course, it's a 2-week course. They feel great forever. I would say more often people feel great for about a year, and then we often have to repeat it once a year kind of thing, but it's definitely something worth exploring.
Yeah. Is that a treatment that you would like jump to maybe first since it's like it's a short course versus like a Linzess or like those advertised current treat or other treatments for IBS
Yeah,
that
that's a good question. I should have clarified. The antibiotic works best for IBS with diarrhea and IBS with bloating. It's not as effective for IBS with constipation. So the constipation form, we start with things that specifically attack constipation. And actually that's a point I should have mentioned is we do treat these conditions very differently. The IBS subtype that's more constipation or the more diarrhea. But yeah, so for the constipation one, we start with good old fashioned fiber and other things that kind of help move the bowel along. Then we'll start with more gentle laxatives. And if those don't work, we get into the more prescription strength medications to treat constipation, like you were just referring to. Linzess is one. Yeah.
Okay, good. All right. So next question is, how often is there a delay in diagnosing endometriosis? And so in your workup of IBS or ruling out other really significant gastric problems, how often do you make sure that what are some things that you are tipping symptoms that you would say, oh, you need to see your gynecologist to, make sure that, you're may not be endometriosis?
Yeah, it's a really good question. I would say, also depending on the age of the woman, that might tip me also just to, make sure you see your gynecologist. But there are certain, even though I said before, the symptoms overlap very much, there are certain symptoms that I think point more towards gynecology than my domain.
Like the
One
cyclical nature of
Yeah, cyclical nature, pain with sex. So, women will definitely come to me complaining of abdominal pain, but if they say, but it's, we're a lot worse during sexual activity, that to me is more unusual with IBS, and it would definitely prompt me to say, I want you to see your gynecologist. Certainly, vaginal bleeding, those things really shouldn't be happening with IBS. So I would have them go there. And really the lower pelvic pain. So with IBS, it's often more mid and upper abdominal. We can get lower, but like really pelvic, to
Mhm.
me, usually signals potentially more of a gynecologic issue.
Yeah, and there's definitely delay in diagnosis of endometriosis, especially if someone doesn't have a family history, because as a there are so many symptoms that are normal to the menstrual period, but in endometriosis it's a big exacerbated.
Mhm.
um so a lot of times people will, and diagnosing it is somewhat difficult in, like, especially younger people, because you don't want to do invasive surgery on like a 14, 15-year-old. So I think that, for younger people, especially adolescents, I think there's a significant delay in diagnosis. In fact, one of my projects during fellowship was looking at a cohort of about 25 young women who were diagnosed with endometriosis. And there was actually a delay of almost 2 years before they were diagnosed with endometriosis. And they had gone to, on average, at least 3 doctors, um, you know, being the pediatrician, maybe a gastroenterologist, and then maybe one or two regular gynecologists before they were diagnosed with the endometriosis. So there's certainly, like, I think, a, a delay in saying, oh, this might be endometriosis. I'm not really sure. There's some gastroenterology. I have some bloating, abdominal pain, GI symptoms, and so they get redirected to different specialists who will do a fine job in their specialty, but it, but may or may not hit the diagnosis on the nose.
Right.
Yeah. So our so getting to question 5, what are our goals for treating endometriosis? Well, we know that it's a disease that causes a lot of pain and inflammation. So we basically, our goals of treatment are to um, decrease inflammation, and what drives this inflammation is estrogen also. So in menopause, we also see a decline in the amount of pain and discomfort due to a declining amount of estrogen. But in that, for fertile you time, which is from puberty to menopause, as the ovaries are producing estrogen, you have a menstrual cycle, and the endometriosis is definitely exacerbated by the increase in estrogen. So the primary ways that we treat endometriosis are, one, diagnosing it and like just debulking it surgically, and then also suppressing kind of the menstrual cycle through usually birth control pills. Um, and then we also have other medications that do a little stronger job suppressing the menstrual cycle. More common, or more recently, in the past we had been using Lupron, which was a GnRH agonist, which was pretty strong and did cause a lot of side effects. It basically put you into like a chemical menopause with hot flashes and such. More recently, in the last couple years, there's been an oral form of a GnRH antagonist with that suppresses the menstrual cycle. It's an oral pill, so much easier than Lupron or injectable shots. And the side effects of the hot flashes are a bit less. And then we can use some add back too to, make it such that the hot flashes are not so severe. So in addition, we also recommend doing NSAIDs to some extent. We know that long-term use of the NSAIDs can cause its own problems like gastritis. So more our focus is on suppressing the menstrual cycle and like estrogen therapy. So those are usually our goals for treating the endometriosis. And surgery definitely helps, and then hormonal suppression afterwards usually will lengthen the time between the amount of buildup of endometriosis and your subsequent surgery. So we're really trying to decrease the number of surgeries that you'll need, but it is somewhat of a chronic condition, and people do end up having, surgeries every 5 to 10 years to clean up the endometriosis oftentimes. So similarly on that same line, what are some goals for treating IBS, which is another, obviously chronic condition?
Yeah, it is chronic. The one thing that we try to establish early on is the concept that irritable bowel, while it certainly can be extremely uncomfortable, debilitating, all of these things, it's not medically, or there's not something that you're going on in your body that's harmful on a long-term basis. So I mean, that's a good thing. It's not like, for example, Crohn's disease, where there's inflammation, and over a long time that inflammation can cause a lot of damage and complications. That's not the case with irritable bowel. It's never going to cause narrowing or ulcers or bleeding even. But like I said, it can really affect someone's day-to-day life and their quality of life. So the goal really is to get that quality of life to the best possible level. And with almost every GI condition, I think in irritable bowel in particular, we have to think about all the factors that can affect it, including stress, for example, and just mentally. And it's a little bit of a catch-22, because if you're feeling uncomfortable in your stomach, that's going to cause you to feel upset or anxious, but certainly being anxious and upset can definitely make your IBS symptoms worse. So we talk a lot about stress management and acupuncture, meditation, yoga, whatever someone can do to really decrease the stress, because we know that the stress hormones very directly can affect everyone's gut, but particularly people with irritable bowel.
And endometriosis too.
Yeah, I'm sure. Right. So we talk about that. We definitely want to, get those symptoms under control. So if it's diarrhea, we talk about different foods that may be contributing. We might try some eliminations of foods. And, sometimes even if we've cut out, we can't find a specific food trigger, but there's a persistent diarrhea, sometimes we will use anti-diarrheal agents in a low dose and chronically. And that might sound not so great, but actually can be quite effective. So we take each symptom individually and try to pick the right path. Like I said, for bloating and diarrhea, there's a pretty effective course of antibiotics that we often use, but it's a little bit different depending on each person and each subtype.
Yeah, and I think that nutrition, and this will segue into our last kind of comments about nutrition and endometriosis and IBS, which I think that there is quite a bit of overlap in our recommendations for improving your symptoms with diet. So in endometriosis, there has been some research looking at omega-3 fatty acids, and these are found in fish such as salmon and tuna, and some nuts like walnuts. And I think chia, I believe, also is pretty rich in omega-3 fatty acids. And these omega-3 fatty acids help decrease inflammation overall. They improve your cholesterol. But in the setting of endometriosis, it is helpful for decreasing inflammation, which is one of our goals for care and for treatment. So that, in addition to some monounsaturated fatty acids that are found in avocados and also some other nuts, have also been shown to decrease inflammation. There's also some supplements that are in the experimental form. Curcumin, or as extract of turmeric, curcumin. I had done a little bit of research in endometriosis and use of curcumin, and in a in vitro model, a mouse model, it was shown to some curcumin extracts were shown to decrease the size of the endometriosis implants. So that was sort of like a phase one sort of a trial, but I mean, there are definitely some interesting literature about curcumin, and we all know that curcumin has a lot of anti-inflammatory properties for which it's used for quite a number of inflammatory disorders. So, using it for endometriosis wasn't that much of a stretch. So, interesting research coming out on that. In addition to magnesium supplements, have also been kind of shown to improve some of the symptoms of endometriosis by decreasing some of the smooth muscle. That it's a muscle relaxer overall, so it can decrease some of the irritative symptoms of endometriosis. So also, there is a lot of overlap between some of the and undiagnosed gluten allergies in addition to dairy allergies. So some of the suggestions, if those inflammatory or those conditions potentially could be a mix in the diagnosis, are to decrease or go for gluten-free, like a trial of gluten-free or dairy-free diet. And in New York, it's somewhat easy to do. I think that a lot of people have a lot of food allergies, and the availability of gluten-free and dairy-free options is pretty good in New York, at least I've found. And so those are some other changes in diet that we recommend for women with endometriosis that might have like an undiagnosed like gluten sensitivity or undiagnosed lactose sensitivity or dairy sensitivity. And certainly for IBS, I think there's a lot more nutritional, research and recommendations involved, including the low FODMAP diet, which is pretty extensive. There's a pretty extensive list on the ibs.org website. So I couldn't remember all of the low FODMAP things, but I did cut and paste a few of the things. Should I go through that, or do you want to talk about? I'll show you. So these are some low FODMAP good foods, including some vegetables and legumes on the left side in the green, and high FODMAP vegetables and legumes that can cause some gastrointestinal issues. In general, how do you counsel people about FODMAP and like picking and choosing good and bad foods? It's a little bit overwhelming for sure. Oh, I think you may be muted.
Sorry about that. Yeah.
Oh, perfect. Okay.
Yes, it definitely can be overwhelming, and that's one of the reasons why we don't start with the low FODMAP diet. We don't go to it right away. We kind of reserve it a little bit later in the pathway. I would say in terms of nutritional advice, the first thing we do with someone with IBS, and here we're talking really about people with IBS with a lot of bloating and gas, is to recommend, we've already checked everyone for celiac, because like I said, this is a diagnosis of exclusion. So we want to make sure they don't actually have celiac, which is a true, immune reaction to gluten or protein in wheat. But that doesn't mean they may still be intolerant to wheat. And so some of the simple things we try first are relatively simple is, lactose. We say cut out all lactose for just a week. It doesn't take long to figure out if you're lactose intolerant or not, or if that's contributing to your IBS symptoms. So we start with that. And if that doesn't make a difference, we'll advise patients to cut out gluten for a while and see if that makes a difference. Fructose is another thing we consider cutting out. And if the gas and bloating is the predominant symptom, there are some very kind of notorious gas producing foods that we, and it's a shorter list than what you're showing on the slide now, that we'll talk about trying to cut out, things like beans and Brussels sprouts, broccoli, prunes, apricots, things of that nature. But if those don't work, that's when we start saying, okay, maybe now it's time to really try the low FODMAP diet. And what is a FODMAP? It's a very long-term fermentable oligodimmonosaccharides and polyols. That's the FODMAPs. But these are basically short-chain carbohydrates that are not very well absorbed by your body, but then in your intestine, they draw water into your intestine, and they're also digested by bacteria and produce a lot of gas. And so you don't want something that's going to bring in a lot of gas and water, because that's what can cause some of the bloating and discomfort in irritable bowel, and maybe even in endometriosis. We don't know. So that's the goal here, is to get those out of your diet so that you're not producing all of that discomfort. And generally, it's something that we're not saying you have to do this for the rest of your life, because as you can see from the list, it is very restrictive, but it's something if you can try to stick to for a few weeks, and maybe as long as 4 weeks, to see if it's really making a big difference. And if it does, then we kind of slowly reintroduce some of the foods that are on the high list to see for you as an individual, which ones are really problematic or which ones are you kind of okay with, so that you can not have to avoid everything on the high list for the rest of your life. But
Right.
that's generally how we do it. And it's also helpful to have a nutritionist working with you, because it can be quite complicated.
Yeah, certainly, certainly. Um, so I guess getting back to our last question is regarding probiotics and endometriosis and IBS. And there has been some research looking at the gut flora of ladies with endometriosis and without endometriosis. And they have noted there's a significant difference in the microbiota of the gut. In women with endometriosis, they actually found that there's less lactobacillus than in women without endometriosis. So they have been, doing studies of probiotics, and it has helped a lot of the symptoms, a regular probiotic. So I think that it's not a fact, but I think it's certainly some good research and good evidence that a probiotic can help a lot of the symptoms there's some symptoms of endometriosis. And so we definitely recommend doing a probiotic or taking a probiotic regularly if someone has some pretty severe bowel symptoms and endometriosis.
Yeah, I think it's a somewhat similar situation in IBS, where, it's definitely something most people recommend, but the science isn't perfect. There have been some interesting, promising studies, but, on a very large scale basis, where the most perfect studies have been done, not yet. But I think certainly in the GI, system, we know how important a well-balanced microbiome is. And so irritable bowel seems to be a manifestation of an unbalanced microbiome. And so it makes logical sense that probiotics would work. I think one of the issues with really any probiotic research is there's so many different strains of bacteria, good bacteria. So to figure out which strain is going to work for which condition, or even for which person, it might be different for different people. But one of the types of bacteria that seem to be most promising for irritable bowel is bifidus. There are different strains: Bifidobacter infantis, Bifidobacter rhamnosus. There are a few different ones, but basically I would say probiotics is certainly something to try for irritable bowel.
So is there a good recommendation for a probiotic for irritable bowel, and maybe it might overlap with endometriosis? I know like high colony count is a good way to go, and maybe something with multiple strains of different bacillus also is recommended. What are your thoughts on
I
that?
would say for IBS, if we look at which ones have been most well studied for IBS, it really is the strain of Bifidobacter infantis. So it goes by Align as the brand name of it, but That is, I would say, one of the strains that has been most well studied, but these days, a lot of the strains out there have been studied with some promising results. And I wouldn't get too hung up on the, 1 billion versus 10 billion, because each supplement has sort of been optimized. 1 billion, for example, of the Bifidobacter infantis is totally what you need. You don't need 10 billion of it. With other strains, you may need more. So, hopefully the people that are preparing these supplements are giving you the right amount. I wouldn't assume that 20 billion is better than 10, or which is better than 1. But yeah, in terms of IBS, one of the ones that's been most well studied is the Bifidobacter infantis.
All right, interesting. Great, great. All right, I think we went through our top 10, and if there are any other questions from the audience, we're happy to take them. Michelle, let me see if I can look I'm gonna stop my screen share for just a second and look in the chat. All right, we have currently no chat questions. However, do you have any other topics of discussion for endometriosis, IBS that we can close up with?
No, I just think, I think it's really important for people who have one of the, or think they have one of the conditions, to really be aware that they may have the other. And, if their doctor isn't bringing it up, maybe they should bring it up as a possibility, because
Yeah,
today there is a large amount of overlap at times.
yeah, there definitely is a lot of overlap. And since we have such a great GI department at Trinity, I always recommend, hey, I think you should also see gastroenterology, just to make sure that you're not having, other things besides endometriosis. You have a lot of, bowel complaints, etc. But like I said, a lot of the times they're already working with a gastroenterologist, so which is wonderful. And I think that's part of a nice part of our healthcare system, and is that we do tend to refer to our specialists and our experts and we have that availability, because like in smaller cities or like smaller communities, there isn't that much availability or I guess collaborations with specialists, and that's definitely a nice thing about NYU. It is very collaborative, and really has been a great place to work for the last several years.
I agree.
Okay, well, it's been a pleasure to host this webinar with you, Dr. Rajapaksa.
Yeah, thank you so much. My pleasure as well.
And we'll be collaborating, I'm sure, again in the future.
Yeah, absolutely.
And have a wonderful trip to Rome.
Thank
And
you.
in the
Thank you
next
so
couple
much.
weeks.
Bye, everybody.
All right.